All right. Thanks everyone for joining tonight. Tonight we're going to be doing our healthy lifestyle talk on colorectal cancer, as March was Colorectal Cancer Awareness Month. My name is Adam Hawkins. I'm the Chief Medical Officer at Northern Inyo Healthcare District, and I'm also an ER physician. We're lucky enough to be joined by two of our acute care and general surgeon, Dr. Robbin Cromer-Tyler and Dr. Connor Wiles. And Dr. Cromer-Tyler, do you want to introduce yourself to the audience?
I'm Robbin Cromer-Tyler. I've been here on the first, it'll be the beginning of my 18th year. Um, I have been providing colonoscopy and surgical intervention for colon cancer during that period of time. I am originally from Reno, Nevada, went to the University of Nevada School of Medicine and trained in Memphis, Tennessee.
Awesome. And Dr. Wiles, how about you? Do you want to give us an introduction? Let us know a little bit more about you.
Yeah, thanks so much for the invitation to be a part of this and discuss this topic. Some of you know I recently moved here in June and I started practicing at the hospital in August. So far, I've had nothing but positive things to say about the area and community, and really want to thank everyone for welcoming me with such open arms. It's been a privilege taking care of you and at the same time enjoying this beautiful place that I'm now calling home. When I'm not in the hospital, you'll most often find me skiing or exploring the alpine lakes in the summer with my dog Togo. I was born in Alaska, in a small town, pretty similar size to Bishop, but mostly grew up in Portland, Oregon. I did my undergrad in biochemistry and then completed my general surgery residency at Cottage in Santa Barbara. In addition to taking care of the broad spectrum that is general surgery, my professional focus has been taking care of colon cancer, reflux disease, thyroid diseases, and helping patients with renal disease through dialysis access with fistulas. So thank you.
Awesome. Well, thank both of you guys for your time. So tonight we're going to be focusing on colorectal cancer and screening for colorectal cancer. Unfortunately, colorectal cancer is very prevalent in our society and something that most of us have been aware of for a long time. And I know everyone has heard of screening options for colorectal cancer, and it can be confusing to kind of keep up on when you're supposed to be screened and at what age range if you have certain risk factors. So tonight, I'm hopeful that we'll have be able to shed some light on that for our patients out there in the audience. So I'll start off just for our audience. I'm going to be asking our surgeons some questions, and then at the end, if you guys have any questions that you want to add in the chat or on YouTube, Barb, you can let us know if there's any questions from the audience members that we'll get to if we haven't answered them by the end of the talk. So to kind of kick things off, what puts patients at increased risk for colon cancer?
So increased risk, these are broken down into both modifiable and non-modifiable risk factors. Non-modifiable meaning things there's nothing we can do about. And those include a family member or family members with colon cancer, male gender, presence of inflammatory bowel disease such as ulcerative colitis and Crohn's disease, as well as specific inherited syndromes. Thinking about the modifiable risk factors, the things that we can control are tobacco and alcohol use, and then diets with heavy consumption of red meats, low fibers, obesity, and lack of physical activity.
I think it's important to remember that only 25% of colon cancer is from somebody who has an increased risk factor, basically a genetic predisposition. So 75% of the time, you're the first person in your family to have colon cancer.
And that's a scary fact, Dr. Cromer-Tyler, to think that maybe it's harder to track your history and know if you're at increased risk for developing colon cancer or not. So with that in mind, what symptoms are concerning or might clue someone in that they may be experiencing the early stages of colon cancer?
Well, unfortunately, colon cancer doesn't present with symptoms early. That's the whole reason we've begun colon cancer screening. The bleeding, blood in the stool, changes in the bowel habits, unexplained weight loss, those unfortunately are symptoms that present late.
Yeah, other things, constipation, change in the caliber or size of your stool, obstruction, bloating, all those kinds of things. Yeah. And many of these symptoms that we both just discussed can be related to other processes, however, definitely warrant evaluation by a provider. And many of them are, as Dr. Cromer-Tyler mentioned, kind of late stage symptoms. So that's why we encourage the screening at an earlier age.
Well, so it sounds like even all the more reason to kind of know if you do have any modifiable risk factors to know if you're maybe at increased risk and to have a conversation about screening options maybe earlier. What or is colon cancer more prevalent in certain populations rather than other populations?
Well,
Yeah.
go ahead.
Yeah, the Native American population, it's about 48.6 in 100,000 Native Americans will be diagnosed with colon cancer. And that's followed closely by African Americans and then Caucasians and Hispanics. The Asian population, interestingly, has the lowest incidence, which is thought in some way due to diet.
It's really the developed world where we see colon cancer predominate. Some of that is changing slightly, but basically, if you're in a first world country, you're more likely to have colon cancer than not.
Well, Dr. Wiles, you mentioned some modifiable or risk factors that the patient or that you can control, and then some risk factors that are non-modifiable or maybe a little bit out of our control. So with those modifiable risk factors, what are some things our patients can do to help hopefully prevent developing colon cancer?
So kind of as we discussed previously, you could limit your alcohol intake, quit smoking, maintain a diet high in fiber with lots of fruits and vegetables, supplemental fiber if needed with something such as Metamucil or FiberCon or pretty much any brand that's a powdered fiber supplement. And then limit your intake of red meat. And then probably the most important thing you can do is undergo screening starting at age 45. Because even with the best intentions and the best diet and not smoking, etc., sometimes you're just unfortunate and you have this polyp or genetic syndrome that ends up growing into a colon cancer that we may have not been able to detect at an earlier age, and that does forego the highest chance of survival. The earlier we catch it, better chance of a cure.
And I emphasize that to people by telling them my own family story, which is I nagged my brother till he was 57 to have his first colonoscopy. And lo and behold, he had colon cancer. But the thing about it is it was confined to the surface of a polyp. So by removing the polyp, he was completely treated. It just means afterwards he has to have increased frequency of screening, as do I.
So you mentioned the 45 age. My first memory of even hearing about a colonoscopy was when I was young and my dad turned 50 and was very nervous about undergoing his colonoscopy for the first time. And then even when I was in medical school, 50 was just an easy number for me to remember, and everyone knew that 50 was the kind of recommended age when screening was start. But it sounds, as the talk of this, or as the title of this talk alludes to, it sounds like 45 is the new 50. So why was that change?
Well, we've been seeing an increased incidence over the last 20 years. Realize that databases have become more facile for people to look at and gather information. And there's been an increased incidence of about 1% per year since about 2015 in the incidence of individuals less than 50 having colon cancer. So that was the impetus to move the screening age down to 45.
And when was that, or approximately, is that a relatively new recommendation within the last 5-10 years?
Yes, it really has been around probably for about 10 years, but really to get insurers to support it, it's really been the last 5 years.
Mm-hmm.
So say someone goes through the steps and gets screened, and unfortunately they are diagnosed with colon cancer. What are kind of the next steps that a patient might undergo after being diagnosed with colon cancer during a colonoscopy?
So there's a number of things that happen after that point. We conduct a series of tests, including blood work, further imaging to determine the stage of the cancer, which is the most important thing. If it's an early stage, then oftentimes we can offer an operation to remove that part of the colon that contains the cancer, and then the patient can be cured and kind of goes into a similar situation that Dr. Cromer-Tyler described, where you're just at an increased, screening time where it's, every 1 year, 3 year, 5 years, et cetera. Or if you're at a later stage, then oftentimes there's a combination of therapies, including medical oncology and chemotherapy, followed by a surgery at a later date to then remove what's remaining of a tumor after the medical therapy.
Most of the testing is there to evaluate if the tumor is confined to the colon, if there's evidence of spread, even through the wall of the colon or into lymph nodes, then the secondary treatments come in. And in today's world, many times that means preoperative chemotherapy rather than postoperative.
So Dr. Cromer-Tyler, you during your story about your brother, you mentioned polyps. So can you explain to us what exactly a polyp is and how they turn into cancer, or if all of them turn into cancer? What exactly should a patient understand about polyps?
Well, polyps look like a heaped up mass of tissue, just like a bump on the colon. Sometimes they can be big and have a stalk, or they can be flat. What we know is that within those cells, there are mutations going on that are allowing these changes to occur. What initiates that, we don't know. But we remove them and evaluate them for what cell type they are and how large they are, which helps us determine your risk based, again, across very big databases for cancer developing. I believe Connor also used the National Cancer Consortium Network algorithm, which is quite complex, to determine the frequency of colon cancer screening done based upon cell type, size, and number of polyps.
Yeah, there's a lot of intricacies to that. I do use the NCCN quite often. I mean, obviously, like the very, broad and even some of the more granular details, but as she alluded to, I mean, there's like a whole series of graphs where it's like if you have 4 of this type of polyp and one of them is greater than this size, and if there is this, amount of dysplasia or this grade of dysplasia, et cetera, then it puts you in these different buckets. So as she said, we don't really know what causes you to go from, step 1 being normal colon to step 10 being an invasive cancer, but there's a lot of data that shows us that if you have very specific characteristics of certain polyps that, you're at this point in the pathway and then need increased screening or, an additional resection, et cetera, et cetera.
So the expansion of using screening techniques has shown, particularly since the 2000, a decrease in the incidence of the disease and a tendency towards earlier diagnosis. And for colon cancer, early diagnosis correlates with survival.
So it sounds like there may be 2 steps in the diagnostic process during a colonoscopy. There's the visual diagnosis, so the way the shape of the polyp, if it has a trunk or if it's just kind of a blob mass coming off the colon. And then one of you mentioned there's kind of a cellular analysis. So what can a patient expect as far as coming out of the procedure? Are they going to know right away if they have colon cancer, or do they have to wait for the results to come back from more testing?
Usually we can't tell what cell type it is by looking at it. So what we would do is send it to the pathologist. And once we get that, we can make a better evaluation. We're very fortunate here that we get most of our pathology back within a week, whereas I have workplaces where it could take a couple of weeks to get it back. The patient will know when they leave the hospital having had the colonoscopy whether we removed them or not. And as soon as we get them, we inform them of what they were and what that means for screening. Colon cancer, usually, if you can diagnose colon cancer at the time of a colonoscopy. It's usually pretty advanced, and it's pretty obvious.
Thank
There are
you.
a few things in between that give you some hints, so there's some, very small sessile, which is kind of that more flat one that she's talking about, is, you never know. We always send it to pathology, but it's more likely that that's going to be benign, that something that's large, pedunculated, has a stalk, is kind of angry appearing, more stuck to the wall. All those kinds of things are characteristics that, I would share with the patient at the time of the colonoscopy, but then, as she alluded to, would follow up with the pathology, which is, the true diagnosis at the cellular level.
Perfect. Thank you, guys. All right. So I think we should talk about the preparation for a colonoscopy. Being an ER physician, I've heard all kinds of myths and tall tales about what works and what doesn't work, and how uncomfortable it is. So a lot of people have heard bad things about the colonoscopy prep process, but can you talk about what exactly the prep involves and what other, maybe start with that, and we can ask a couple of follow-up questions.
Well, having done it 3 times myself, I can tell you that all the stories are worse than it really is. There's occasional person who can't tolerate it well, or it just doesn't work. It's not a weight-based process. It's, again, clumped from big databases, what works for most people. We have been able to go away from the gallon jug of Go Lightly to slightly less volume in something that you can mix, and something you could palate, like Gatorade, Crystal Light, white grape juice, whatever. I used water the last time I did mine. And we do have you drink it fairly rapidly, but if you can't, we can work with that. The big thing is the first time you go through it, it's an experiment to see how it affects you. Some people will clean out rapidly, very quickly, and other people may be up at night going to the restroom more frequently. We also do split dosing, where we do some of it the day before and then some of it early in the morning, the day of. And that's been found to give us better visualization. The whole goal is to be able to see 90% of the colon wall when we do this.
Yeah, and you can't trick us. So you have to follow the directions, because we are going to see the result of your preparation. And I think that most of my patients have all, everybody wants to do a good job, but it's mostly kind of a hassle for them, because if you come the next day and we can't see, like she said, then we can't safely clear you of disease, and then you have to repeat it. And so it's kind of a joke, but yeah, it's definitely important to make sure that it's thorough so that we can see everything, because you go in there and all the walls are covered. There might be a polyp hiding under something that, that we would miss, which we obviously don't want to do.
And as I said, there's a certain percentage of people, it's just not going to work. The simple 1-day prep that we use on most people, we have to go to 2-day preps, which take longer and are less pleasant. But I think most people, their biggest complaint is the volume they have to drink and the fact that they're on clear liquids. But having had a gastric bypass, I can tell you clear liquids is better than nothing.
Yeah, I'd say most patients anecdotally that I've spoken with that have gone through the prep process, it's obvious the anxiety associated with preparing for it is usually worse than the actual reality of going
True.
through it. And it'd be terrible to put yourself not only through the prep and lack of eating and the procedure itself, only for it not to be sufficient, and then having to go back and do that again would definitely not be ideal. Dr. Cromer-Tyler, you mentioned some patients it's just not going to work, or perhaps some patients are just fearful to actually undergo the procedure for a variety of reasons. So what other ways can people be screened for colon cancer, and are those alternative options just as good as a colonoscopy, or they're not quite as sufficient?
There's kind of a gradation of our hierarchy, if you will, of sensitivity and results. colonoscopy being the most reliable. The next most reliable is a newer DNA study of the stool. It's actually a box that you send your whole stool back to this lab, and they test it against some DNA probes. And if it's positive, that's an indication for a colonoscopy. The thing about the other techniques, including the DNA test, is that they're repetitive. You have to do them every 3 years or every year to keep on top of it. I think that probably people who have been insured through Kaiser are familiar with flexible sigmoidoscopy on every 3 years and routine testing. And I think in a structured medical program like that, they stay on top of it, whereas in more independent monitoring, it's hard to stay on top of that kind of monitoring unless you do it yourself. So for us, most people have a hard enough time remembering once every 10 years, once every 5 years, once every 3 years. So we create a database on our patients once we've done a colonoscopy of how often we do them. Colonoscopy has a sensitivity rate between 90 and 95%. The DNA test has about 85%. All tests have a false negative rate and a false positive rate. So we can find a polyp and it be nothing, or we can miss a polyp. But still, it's the most sensitive of the tests.
So we've mentioned insurance a couple of different times. Are these alternative tests like the box you described, which I think a lot of people maybe have seen commercials for, products like Cologuard, are those covered by insurances typically, or is it just a pen and it's nuanced? How does that generally work?
Most of them that I have found over the years have now become acceptable as a non, as it's no longer considered nouveau or experimental. So Medicare covers it up to 83 and a half. Medi-Cal covers it. Some insurers may still be on the fence about it, but I have not encountered many that are resistant to it.
And it sounds like the colonoscopy, the insurance companies agreed with reducing the early recommended screening age of 45. So generally, most patients at that age are going to be covered by insurance. Is that safe to assume?
Yes, and part of that is the reason that if you progress and have colon cancer, the amount of money invested in your treatment is so high that the prevention over time is worthwhile.
Awesome.
Yeah, I think once all the societies started agreeing on it, it was like the general surgeons and then the Society of Gastroenterologists and all that, like everybody's data was showing the same thing, that it was, people were getting the disease earlier, and earlier detection was not only saving life years, but from the insurance perspective, it was saving them money. And so, as sad as that is, that's ultimately what got it to change. So.
Well, I'd like to ask just a couple of other questions about the procedure itself. I know having a procedure of any kind in a hospital or a clinic is always kind of anxiety provoking and nerve wracking, especially a procedure like a colonoscopy where, lots of people have undergone the procedure and there's a lot of kind of mythology around it, and a lot of kind of rumors being spread. So is the procedure itself painful? And if so, what measures are taken to allow the patient to be more comfortable and to tolerate the procedure?
It can be uncomfortable. Overall, I usually tell my patients that the worst part is the prep, even though it's not that bad. But by the time you get there, it's a very safe environment. At our institution, it's done in the hospital. There are one, if not two nurses, as well as a tech and myself or Dr. Cromer-Tyler in the room, and then sometimes an anesthesiologist. And so we use a combination of a sedative and then painkiller to make you as comfortable as possible. And that's for for your own comfort, and then also so that you're able to relax and we're able to progress the scope through your colon without you fighting. So most people are sort of in a lucid dreamlike state and don't remember much of it. Some people are in no pain at all and end up watching the entire procedure. And it's kind of a spectrum, and we sort of, have a conversation and titrate the medication to that patient's experience and kind of what's going on. But it's never going to be a situation where you're laying on the table and you're screaming and you're uncomfortable and we're moving through regardless of how you feel. It's very much a relationship and making sure that you're comfortable.
So if you can't get the patient relaxed, the risk of complication goes up. And so if you do all that you're allowed to do with conscious sedation, then that's a reason to stop or call for an anesthesiologist.
Yeah, and I'll say that Northern Inyo Healthcare District is very fortunate to have the facilities that we have. The OR suites where these take place are beautiful. We have anesthesiologists 24/7. So we certainly have the resources to try to maximize our patients' comfort. And I rarely hear any issues with our patients being uncomfortable, other than the prep and just kind of the anxiety that goes along with preparing for a procedure.
Yeah, I would say I've only been here 6 months, but on that line, and then also what Dr. Cromer-Tyler mentioned earlier about how we keep track of patients in the database, coming from other places, it's pretty darn streamlined. Like if I have a patient with a normal colon and no family history, I send my office staff a message and I say, this is a normal colon. They can be placed on a 10-year cycle. And then, that patient will then get a reminder phone call, et cetera, a few months before they're due. And so that part has been really nice. And then, doing these in the OR with full staff, anesthesia, et cetera, like basically every resource at our disposal to make the patient comfortable and the procedure go well has been just such a nice experience as the provider. And I imagine as the patient, it makes it much easier as well.
Well, I can verify I've had 3 here, all done. I've had 3 colonoscopies all done here, and I have absolutely no recollection of the procedures. So
that's a good thing.
That's a personal pitch. So it saves lives, and it saves a lot of heartache if you have for your family. If you're going to go through cancer treatment, let's get it early. Let's get it out as quickly as we can. And the best way to do that is to do screening.
Yeah, or let's prevent it. I mean, the other thing that, you mentioned earlier that the colonoscopy does that none of the others do is we remove pre-malignant polyps. So something that, doesn't have bad cells in it now, but may develop over time, we're removing that, 2, 3, 5 years before it's had the chance to grow into something like that. And so, not only is it cheaper, better, earlier if we find it early, but I mean, sometimes we're preventing it, which is, a true benefit.
Absolutely. I think that's what makes this screening for this type of cancer in particular so important is to both your points. You can prevent it from ever happening. And if you can stop it in its tracks if it's found early enough, and if not, then it can really be quite a deadly disease if left untreated and unrecognized. I'm about to finish up with my questions and wrap up here. So if anyone in the audience is thinking of questions, but I'll finish just with a simple question: is if a patient that's listening or a patient or a audience member has a family member, how do they go about making an appointment to see you guys? Do they need a referral from their primary doctor? Can they call the clinic directly? Does it just depend on their insurance? What would you recommend the first step towards scheduling a screening colonoscopy would be for audience members?
I would say make the phone call to the office. If your insurance requires a referral, then usually our clerk knows that already from the experience of working with them. Sometimes part of the reason we see patients before surgery or before colonoscopy, excuse me, is because there are other medical issues that may be more important to address first, or we have to assess if you can tolerate being sedated. And that's why we see them. because we can assess, can you walk across the room without getting short of breath? If I give you a drug that's going to suppress your respiratory rate, are we going to have a problem? It helps us decide how to set it up. What else? And I think that's pretty much the way it works here.
Yeah, and I think, that is something that was new to me when I came here. I think in a lot of places screening colonoscopies, there's not necessarily a clinic visit before. And I was kind of wondering why this was the case here, but it's a process actually I've fallen in love with. It's really nice. You meet the patient before, you have a really thorough discussion about what the prep's going to be like, what the colonoscopy is going to be like. And then, pending the results of the colonoscopy, you're starting this journey with the patient, right? You're kind of one of their team members. And so if you find something, then you've already sort of set this foundation and groundwork, and then you work through that together in a stepwise fashion as you move forward. So, it really is. I mean, it's a hassle to come for, 20, 40-minute appointment, however long it ends up being. But I think that, in the long run, it really is, it's a pretty great thing. And then we're also identifying risk factors that may make it so that we can't do that procedure here, or that we're aware of them when we, give you sedation, so that we can safely do so.
I agree. I think having our patients see our surgeons before their procedure is honestly such a service to the community and the patient. It just allows the patient time to get their concerns addressed, and ask questions about the procedure, and really sets them up for success. So with that being said, those are all my questions. This is a changing field, so I learn a lot every year when we have this talk. So thank you guys so much for your time. At this point, if anyone in the audience has a question and they'd like to unmute and ask, if you're on the Zoom, or if you want to type in a question on our chat, we'll hang out for the next 30 seconds or so if anyone has a question. And if not, thank you so much to both of our surgeons, Dr. Wiles, Dr. Cromer-Tyler. Thank you so much to Barb Lahan, who sets all this up for us and makes sure it runs smoothly.
Yeah, thanks for having us. Very much
Yes,
appreciate it.
thank you very much.
All right, Barb, if we don't have any questions from the YouTube audience, we'll go ahead and let everyone go for the evening.
I have no questions, sir.
Awesome. Thank you all.
Thank you. Nice to see
Thank
you all.
you.
Take
Good
care.
night.